are you ready, Dave?
I am ready.
Okay, quick first question. How many of the SCADs you see also have FMD?
So it's a subject of the paper that's not quite out yet. It's probably between a third and a half. The answer is it depends on which imaging modality you used and how sensitive it is. It's probably, if you look hard enough, you can sometimes find some little bits of irregularity, but real FMD, where you get the typical dilation narrowing, is maybe, as I say, somewhere between a third and a half of patients. What I think is important to say about FMD is this. Our experience of FMD in SCAD is that it is a pretty benign condition. So sometimes you've had SCAD, you've had a heart attack, and then someone piles in and says you've got fibromuscular dysplasia as well. You've already got something called spontaneous coronary artery dissection, and now you've got fibromuscular dysplasia. You're really gathering diagnoses of great length that have acronyms, and it feels a bit terrifying. But actually, our experience is that FMD, for the most part, is a benign problem. We don't usually do serial scans. The imaging studies that have been done internationally say it doesn't seem to change a great deal over time. It sometimes makes a difference for our decision making about whether patients should be taking long-term aspirin or could maybe stop aspirin depending on the particular clinical situation. And sometimes it's associated with other variations, little dissections in arteries elsewhere in the body, or a little dilation of an artery elsewhere in the body. And those kind of things sometimes we need to keep under surveillance. We need to watch. But again, from the patients that we've been keeping under surveillance for these things, they don't seem to change greatly over time. So in terms of the number of patients that we screen for which we actually need to do something about a finding, that is really very small. So the screening is there because it helps us to guide your management and make sure that if there is something we need to keep an eye on, we're keeping an eye on it. But I think sometimes there's, if you like, the anxiety about an extra diagnosis of fibromuscular dysplasia is probably not founded. It's not something that's too terrible. It seems to be quite different from people whose first diagnosis is fibromuscular dysplasia. So whose main problem, if you like, is fibromuscular dysplasia, where they seem to have more issues related to fibromuscular dysplasia than our population of SCAD patients with FMD. And I think that, as we understand a bit more, there does seem to be a difference between those two groups. I know that wasn't your question, but I wanted to mention it.
Thank you. Great detail as always, Dave. What is the percentage of men with SCAD?
Less than 10%, about 8%, something like that. But they're definitely out there. We're very, as you know, actively interested in them. They're potentially a particularly important group for the research because of the very fact that obviously they don't have issues with cycling female sex hormones or declining female sex hormones after the menopause. So the very fact that they don't have this changing biological scenario, which can cause variability when we're looking at blood vessels and measurements and things like that, it means that they may be a group that provide particular insights, which is one of the reasons that Alice has been particularly focused on them. What we know about men and SCAD is that seems that their SCAD is sometimes more associated with exercise. That won't be true for all men, but seems to be more so with in some men. But again, we feel that the rules in terms of what to do in terms of getting back to exercise still apply, with those small sort of cautions about the lifting of the heavy weights and so on that I went through a little moment ago. So men, yes, they are a small member of our community, but a really important one. And we're very interested in them, and we're very keen to look after them and make sure that they get also as much profile and attention as they deserve.
Bless them. Yes. Yes, we do have some interaction with some of our men, but I think there's more we could do with them to support them. What can people do if their GP is reluctant to take them off statins or some of the other medication that they've been put on when they don't have an opportunity to come and see you, or, you know, as we know at the moment, appointments are quite a long way off and people are a bit worried about carrying on taking things that they perhaps don't need to.
So 2 questions in one. The statin question. So at the moment, there is no evidence that the pathophysiology, the underlying causes of SCAD, relate to cholesterol. In the same way, of course, as the atherosclerotic heart attacks, the common cause of heart attacks, we know very clearly have a close relationship to cholesterol. So as a result, what we tend to say is that patients with SCAD should be treated as a primary prevention case, as if they hadn't had the SCAD heart attack. So the question for the GP and for the cardiologist is, would you give this patient a statin if they hadn't had their SCAD heart attack? The day before they had their SCAD, would you be thinking about them having a statin? There will be some that do. So, for example, some patients who may have high blood pressure or may have something else in terms of their risk factor profile, or may have a very high cholesterol, there may be an indication there for a statin. So it's not all patients with SCAD don't need to have statins. Some will be. But I think probably most patients with SCAD for that reason probably don't need to have a statin. In terms of kind of, you know, how it's approached, you know, if people, GPs and so on, need advice, we're very happy to respond to advice letters. As you say, we are a kind of specialist unit of me, and so this can create some challenges just in terms of kind of keeping up with, you know, what is a kind of a large number of referrals. In terms of the SCAD clinic side of things, you know, we're doing our best here. We're going to try and run some extra clinics. Again, we ran 4 in August. We'll try and run some extra clinics. So hopefully those of you that have a very, I know we're kind of booking into sort of middle of 2022 at the moment. We'll do our best to try and reel that back in by doing extra clinics. And also, you know, we're doing our best in terms of advocacy. We've been approaching the politicians, and we're chatting up the chairman of the board and anybody that we can think of that might be able to sort of provide us with a little bit of funding to support the service. So it's a challenge, but, you know, we'll continue to try to do our best and obviously to respond to questions as far as possible. But, you know, we just have to put our hands up and say, you know, volume of email, volume of referrals is a challenge, and we're doing our best.
Okay, yes, I know you are, Dave. It's a tough one. So next question. If you had a stent, does it last forever? Does it need checking after, say, 5 or 10 years? What's the situation with stents?
Stents are an amazing technology. Particularly drug-eluting stents, which is what essentially are used these days. Essentially, they stay forever. What happens over time is they get bedded into the wall of the artery. So if you were flying down the inside of the artery after a year or two and looking around, you wouldn't be able to see the stent because the wall would have sort of grown into it, and so you would just see it like the same wall of the artery as you would see before with the surface of the vessel. So it just stays as it is. Again, usually there are no problems. The problems that arise in patients with stents tend to be early, as we talked about in terms of the immediate complications issues. Once they've bedded in and over time, they don't require surveillance. You know, it's just really, you know, looking at and thinking about symptoms. But in this era of drug-eluting stents, you know, problems arising from the stents, you know, 1 or 2%, tiny numbers. Generally speaking, they're a great long-term thing. So, you know, not all patients at the beginning should get them. We've talked about how the research has shown that some people should. And if you were in that camp, that's okay. Those stents will bed in and they will do you a job for as long as you need them.
Very reassuring. Thank you, Dave. Next question. What does ejection fraction mean, and what is a good number? And if another question, if my ejection fraction is really low, does that mean I have heart failure?
Okay, so the first thing to say, which is very important, is that no heart pumps 100% of its volume. So sometimes you'll get somebody who, completely understandably goes, well, hang on a second, you said my ejection fraction is, 55%. Does this mean that only just a little over half of my heart is working? And that's not the case. So normal ejection fraction is anything over 55%. So, 60% is perfectly normal. That's what a heart normally pumps. In terms of if you have got more in the way of scarring of the heart, that's a minority of patients. And again, it's about sort of getting your head around the numbers. So, I will have some patients in my clinic who will have ejection fractions of 20% or lower. And there will be very few SCAD patients who are in that kind of ballpark. So, if you have an ejection fraction of 40%, okay, yes, there's a scar on the heart, there's a bit of damage there. That may have impacts in terms of making sure you're on the right treatment to support and protect your heart in the long term. But, having an ejection fraction in that territory isn't heart failure. Heart failure is the syndrome where you get breathless, ankle swelling, those kind of things. So it's when you get consequences of it. I think heart failure after SCAD is very uncommon. And that's because, again, usually the injuries are not large, and certainly the ejection fractions, again, your bodies are amazing things at adapting even to an injury like a scar on the heart. And I think getting a damage to the extent of leading to heart failure would be uncommon in the context of SCAD. So I think for the most part, remember that the ejection fraction number, is probably not as bad as it first seems. And that's largely because hearts don't pump 100% of their volume. And so the starting point isn't 100, it's 55.
Again, another reassuring answer. Thank you, Dave. Why is it not recommended for SCAD patients to have a follow-up angiogram? And another question, what are the alternatives to angiogram?
Okay, so just to answer the first question there, we know that SCAD patients' arteries are fragile, and there seems to be an increased risk that during the course of an angiogram procedure, that they're more prone to being damaged just by the catheters, for example, just damaging the artery and maybe causing a dissection or something like that. Probably that risk occurs is at its highest at the time of the SCAD. It may not be that vulnerability always exists, but you can understand that because of that fragility, there's a reluctance to do follow-up angiography to look again. Because what you don't want to do is to say, wow, it's all healed, but we've just dissected the artery and now we need to put in 27 stents. Not because of the fact that there's still a persisting problem, but because we've caused a problem by doing a repeat coronary angiogram. So in general, follow-up coronary angiography is not recommended. There will always be exceptions though. And again, I just caution that, the cardiologists usually are who, making the right choices. And there may be scenarios where they just need to look at the stents or check something out and make sure everything's is in the right way. So that's just a small caveat. In terms of follow-up imaging, generally, so the jury's still a little bit out on whether any imaging is required at follow-up. The reason for this is that those follow-up angiographic studies, and there have been some that have published follow-up angiograms, have essentially showed that in the overwhelming majority of patients with SCAD, the artery heals completely. And so at follow-up angiography, essentially, it has returned to a normal appearance. And so the alternative, if you like, to an invasive angiogram is a non-invasive test like a CT scan. And what we have tended to do is to do CT scans in patients, particularly who have had dissections affecting the beginnings of the arteries, the larger bits of the arteries at the beginning or the middle of the artery. The reason for that is that sometimes we've seen the odd change in this area which has persisted in some cases. So that's one reason. And also CT is not very good at looking at little small vessels. It doesn't have the spatial resolution of an invasive angiogram. It's a bit blurrier, if you like, when it gets to the smaller vessels. So it isn't clear that follow-up imaging is necessary in all patients. In fact, I think it is not. In patients who have mid to distal dissections, so in the mid or the very smaller vessels, I don't think it is necessary. And so there will certainly be scenarios where we don't do follow-up imaging to look at the dissection. We make an assumption that it is healed because that is what is overwhelmingly seen in most patients. So most people, it will be no to invasive angiography and probably not to CT follow-up. Obviously, there are the other follow-up scans, the MRI scans, looking at the heart's pumping function and the scarring that we talked about, and looking for at the other arteries in the body, which we like to do from brain to pelvis, which is a slightly different aspect of the question. But it's tempting, isn't it, to say, well, I want to know if it's healed. But there is a cost to knowing that. Invasive angiography, the risk of causing dissections or causing injury. CT, remember, CT scans have an X-ray dose associated with them. Every time you have an X-ray, there's a small increased lifetime risk of cancer arising from it. That's very small, right? So it's important not to make it too big. If you need a CT scan, we make the decision that you need a CT scan, then that's because we're weighing up that little tiny incremental risk. But it's not a free thing. It's not, it's not a freebie to have a CT scan. It just needs to be thought about. Is it really necessary or not? And we're at the moment, the selection that we're doing is towards those patients who've got dissections in the bigger arteries.
Okay, thank you. Right, changing tack here. My doctor has said I don't need cardiac rehab as my SCAD wasn't a real heart attack. I'm not sure what to do in terms of exercise. Is there any guidance?
So hopefully you've seen the published paper that we just put out. Cardiac rehabilitation is excellent in SCAD patients, and I would encourage you to do it. I think, we are working actively. Indeed, Karen and I had a meeting with cardiac rehab group just on Friday, and we have a cardiac rehab nurse who's done a lot of kind of talking around, and I think I'm chatting at the conference in a few weeks' time as well. So doing quite a lot of stuff to try and raise awareness within this group. But I think a lot of SCAD patients get support and benefit from cardiac rehabilitation. It won't be everybody's bag, and that's fine if it's but I think on the whole the recommendation would be go for it, because just doing a bit of exercise in a supported environment helps to build confidence and helps you to start kind of planning ahead as to how to get back to your best in terms of activities over time. It can also help support, we haven't talked a lot about post-SCAD chest pain today, but it is a common phenomenon. And again, doing some exercise in a supported environment with professionals who know what they're doing, who understand post-SCAD chest pain, can again build confidence in terms of saying that it's okay to exercise and work through some of those symptoms. So I'm sorry that hasn't been recommended to that questioner, because I think it is generally speaking good. I hope that some of the discussions that we had earlier about exercise are helpful. I think if you are doing your own rehab, then the little message that I gave there of trying to iron out the fluctuations, try not to go boom to bust with your exercise, and having one day where you try and do everything and then you just feel flat as a pancake for 3 days and can't get out of bed in the chair, and then you have another go. And we see that quite often. Just try and temper the big day, but when you're feeling a bit ropey, just try and push yourself to do something, and so that you can just start to take that little incremental step upwards. And that's advice that I know our cardiac rehabilitation colleagues will be emphasizing if you were able to get support in that environment. But if you're not, have a little think about that.
Thank you, Dave. Just to add to that, we encourage people to go back to their doctor, the referring doctor, and show them the consensus document, which points out that cardiac rehab is useful for SCAD patients. And so hopefully that empowers people to ask for cardiac rehab.
Yep, strongly recommended in all of the reviews and guideline documents. So it's unfortunate that you've been given different advice there.
Okay. I've read that many SCAD patients suffer from migraines. Do we know why?
We do. So it's because migraine and SCAD, do you remember we were talking a little bit earlier on about the common genetic variants? I think I described them as the pack of cards you get dealt with when you're born. What genes have you got in your pack? Well, what it turns out is that some of those genes that confer risk in SCAD also confer risk of migraine. And one of those is the FACTAR1 gene, which was the first gene that we described. It's recognized to be associated not just with SCAD, but with FMD and with migraine. And so it is likely that the reason that such a lot of patients with SCAD have migraine is because of this shared genetic pedigree, if you like, for these conditions. So again, we're happy to provide advice about migraine. It is one of those areas in SCAD which is tricky sometimes, and we can sort of work through it, and obviously it sometimes need to get some specialist input as well as to how to both manage in terms of prophylaxis, preventing, and acute migraine management. But yes, there is a reason why, and it's to do with the underlying genetics of those two conditions.
Okay, thank you. In your research, have those people who have had more than one SCAD had the same symptoms the second time, which alert them?
Yeah, so one of the real challenges after SCAD, is kind of working out the kind of recurrence versus post-SCAD chest pain thing. The recurrence thing, I think the first and most important thing to say is that, yes, it's something that as a SCAD community, we have to get our heads around, but the risk is, modest. So it seems that around 1 in 10 patients will get a recurrent event over, let's say, a 5 to 10 year follow-up period. But of course, if you're, it's glass half full, glass half empty territory. If you flip that on its head, 90% of patients are not going to have a recurrence in the same time frame. So, you're 9 times more likely not to have a problem than you are in that time frame. Over a longer period, we have less available data. It certainly doesn't, it's likely that the risk falls. We're not seeing lots of patients in their 70s and 80s with SCAD, so presumably falls at some point. But we do know some people that have had a recurrence sort of a decade or more afterwards, so it can happen. So yes, it's a risk, but it's a risk that has to be kind of kept in a box of the right size and not allowed to become dominant, if you know what I mean, because otherwise you're sitting around waiting for something to happen that, may never happen, and it's probably is much more likely not to happen than to happen, right? I can't remember the question. What was the question?
Are the symptoms the same the second
the symptoms
time?
are the same. Yeah. Sorry, I started rambling. No, so in terms of the symptoms, I think the important message in terms of telling the difference between recurrence and post-SCAD chest pain, my experience is that patients who've been unlucky enough to have a recurrence, it's not equivocal. They usually know. It's not they're sitting going, is this my post-SCAD chest pain, or is this? They usually know that they need to be seen. So it may not be that it's exactly the same symptoms, but usually there's stuff in there that makes you go, do you know what? This is something I need to get checked out. Often, of course, people will overcall it, and that's completely understandable. With the post-SCAD chest pain problem, lots of patients will be readmitted to hospital after they're SCAD with chest pain. And this is, my message on this is that this is not a defeat. After SCAD, there is a relearning process about your body and trying to work out what symptoms are important and what symptoms are not important, and so on. And so if you end up in hospital with chest pain and its troponin is negative and you're told that you're not having a heart attack, this is not a personal defeat. This is a learning exercise. So you can go, okay, so that isn't recurrence. I can be a bit more relaxed about something like that if that happens again. Our other experience of post-SCAD chest pain, and again, I think this hopefully is helpful to people who are experiencing this, is that it does improve over time. It can take time. We sometimes say it can take 18 months to 2 years before it fades into the background in most people. And sometimes even then, if people have like a family stress or something, it's a bit like your old war wound, I think, in those sort of stories. If you get a family stress, it's like, oh, it's my old war wound. When you get your post-SCAD chest pain just a little bit, that's how it manifests, even sometimes a longer period of time afterwards. But in general, it does improve over time. and I sometimes say to people, and you probably, many of you heard me say this, is that we have to give the heart time to heal. We don't really know what's causing it, but we think it's to do with the healing process. And I say to people, look, if on the day of your SCAD you'd had a really nasty leg break and you'd broken your leg, would you expect at 6 months, even 12 months, for your leg to feel normal? And the answer is no, you wouldn't really, would you? You'd think it would probably be giving you a bit of jip or the odd ache and so on. And maybe you might still feel something 18 months to 2 years afterwards. And the heart is the same. It's sometimes because it's inside us, we sort of feel that, well, it's done and dusted now, it should all be sorted. Whereas actually it needs that time to heal as well. And I think that is part and parcel of the kind of post-SCAD chest pain that people experience. So I'm aware, Karen, that I extemporized slightly on the question, but hopefully I answered it as well.
Absolutely, Dave. Okay, so there was a question about autoimmune conditions, which I think you covered in your talk very well. So I'll jump that one. Are there any figures for the number of SCAD heart attacks per year? And how does that compare to regular heart attacks?
So this is something that, I think we only have a bit of a handle on. And the reason that we only have a bit of a handle on it is because I think that we know that SCAD is underdiagnosed. That's getting better, but it's not yet, a problem that's completely solved. And that problem happens across the whole spectrum. It's from yourselves as patients. There are other patients who don't respond or who sort of, stick with the indigestion idea and just sit it out. And so the diagnosis is never made. And, it's not uncommon for me to see someone in clinic who says, do you know what, I'm pretty sure I had the same thing 3 or 4 years ago, but, I just sat it out that time. So it's the patients not presenting. And also, obviously, sometimes ambulance crews and A&E staff and so on, don't twig or are not thinking about it. And that's obviously what, improving with all of the education, but there's a lot of work to be done there. And so it's really hard to say exactly, how many SCADs happen. Certainly from the clinic's perspective, we're seeing a pretty much exponential rise in the number of referrals, and that's creating some challenges that we talked about a little bit earlier on. But it's also showing you that there's, I don't consider SCAD to be rare. It's not as common as the atherosclerotic disease, but it's not a rare disease. There's a lot of people out there that are getting this, a lot of referrals that we're experiencing. And, I think as we start to see a little bit further beyond the tip of the iceberg, as the diagnosis rates and accuracy is improving, I think, we're coming to realize that actually there's more of this out there than we thought.
Okay, and just as a comment from me really about that is that presumably the new ICD code that is coming into operation next year is going to help, hopefully, with recording the number of SCADs that occur.
Yeah, so it's an important step, of course. So the step one, if you like, is having a code, because that then means that you have the ability to be able to record in the sort of NHS metrics and international metrics patients that have the condition. But of course, the code is only as good as the coder. And that's, again, down to people making the diagnosis, but also expressing the diagnosis accurately in the medical records so that the coders pick up on the diagnosis and get the correct diagnosis. So, as with a lot of things with SCAD, it's a journey. But I think it's a journey in which we're making incremental steps in the right direction. But it doesn't mean we still don't have a journey to travel.
Okay. So what are the other conditions that can be mistaken for SCAD? You mentioned earlier in your talk.
Yeah, there's a range of these things that where there are mimics, and you can read about them in that paper if you like. Essentially, obviously, the commonest cause of heart attacks is atherosclerosis, this common form of heart attack disease. And sometimes atherosclerosis can mimic SCAD. It can look very like it. just, by the way that the coronary angiogram appears. And again, that's, if you like, part of what we're doing in the SCAD clinic is using our experience to have a really close look and try and sort of, think to ourselves, well, is this definite or is this not? There are other things. So, there's a condition which can go the other way, which is Takotsubo cardiomyopathy. People call it the broken heart syndrome. And actually, sometimes some of the Takotsubo cardiomyopathies, when you look back, are actually SCAD of the area of the distal left anterior descending coronary artery. Don't need to worry about the anatomy, but the area that supplies that part of the heart that balloons in that condition. So there are a number of things, and I think what that paper was trying to do was to, educate and inform people of these scenarios that we see in the clinic where, there are cases which are mimicking SCAD, and the other way round, right? So cases where SCAD looks like atherosclerotic disease, for example, and it's just to sort of try to, increase people's little radar for thinking, hang on a second, this is a let's say a young female patient without much in the way of risk factors, and although this looks like an atherosclerotic lesion, maybe I should do intracoronary imaging to be sure that it's not actually SCAD pretending to be an atherosclerotic lesion. Or in that maybe young male patient with a risk factor or two, where it's not typical of SCAD, again, maybe you do a little bit of extra imaging to just be sure that it really is SCAD and that you're not mistaking atherosclerosis, which is much more common and therefore will also occur even in young patients without risk factors sometimes, that you're getting the diagnosis right. And again, also to help doctors to think about which tests to do when patients are in what we call that gray zone, where you're not quite sure which way to go. How can we try and help, decide one way or the other? And there will be some patients who stay in the gray zone. And, we try and counsel those patients about that. It's not a disaster. Sometimes it means, for example, that you might stay on a statin just to cover that eventuality. And we might do brain to pelvis imaging just to make sure that we've covered the SCAD side of things. So there are ways to deal with it. Not all diagnoses are black and white. And I think, that's important to understand, even with the best will, if you like. But of course, we would talk to to patients individually about those scenarios if they're relevant to them.
Thank you. Another question. I want to have a family. Is there a better understanding of pregnancy after SCAD?
So we're working on an output in this area. So maybe some more news on that at the next meeting. What is known at the moment, I think there's a few things to say. First of all, it is best to avoid unplanned pregnancy. Pregnancy needs to be thought about. There are sometimes medications which can be damaging to an unborn child that patients with heart disease may be taking. That needs to be thought about. Your individualized risk needs to be thought about. That's not to say that, pregnancy can't be considered. And indeed, there are a number of, very successful pregnancies in the SCAD community that we're aware of. It just means it needs to be thought about and planned. It does appear that there is a risk of recurrence occurring during pregnancy or the postpartum period. So during that sort of pregnancy period of 9 months and 12 months postpartum, somewhere around the 10% risk, 1 in 10 again, maybe a little bit less than that during that time period. That risk can't be taken away. So we can't make that risk zero. It doesn't matter how many times we see you or how many times we talk to you or look after you. We can sort of support and counsel through the process, but we can't mitigate that risk. There isn't a magic bullet to take that away. And, again, that's a risk of recurrent SCAD. It's not a risk of dying or something really terrible happening. It's a risk of recurrent SCAD. Recurrent SCAD carries those additional risks, but that would be, again, small risks on top of that. So it's not risk-free, but that doesn't mean it can't be considered and worked through. But it is best discussed and weighed up on an individual patient basis. And that also means we can make sure that your local pregnancy heart team and every area has a pregnancy heart team, are aware of you, and you're sort of plugged into the system, and people know about you and your case. So it's a little bit individualized.
Mhm.
It's important to say it's not risk-free, but that, that doesn't mean it's not a risk that that individual patients with counseling won't take, and many will, and of course many of those will have successful pregnancies.
Okay, thank you. So the next question is about HRT. So choices to help with intrusive menopause symptoms in SCAD patients in cases where expected benefits outweigh risks posed by the treatment. Which treatments can provide the desired minimal effect dose for the shortest period of time? Is that a possibility?
So HRT gets a bad press in SCAD. The reason for that is that, as we know, SCAD has an overwhelming female sex predominance, and it has this association with pregnancy in some patients. And so it is likely that there is some link between SCAD and female sex hormones. But we don't understand that fully at the moment. And it doesn't seem to be that association is as simple as exposure. So to date, it's not been described that, for example, there is an increase in the proportion of patients taking hormonal contraception or taking HRT in the SCAD community compared to the population as a whole. Nobody's ever shown that that is the case. Likewise, it's never been shown that taking hormonal contraception or HRT increases the risk of SCAD recurrence. Now, we're always learning all the time, so we have to keep an eye on this space, but that is the understanding of the situation as it is at the moment. So we don't know that taking HRT in this context increases the risk of SCAD recurrence. That's not been shown. And, again, it's not particularly our experience from what we've seen. So in terms of how to manage the menopause and menopausal symptoms, clearly if patients are able to get through the menopause without HRT, so much the better. We already know, of course, that HRT carries a small increased risk of breast cancer. That's something that's known and is discussed with people and weighed up as part of their decision making. So what you're really doing, if you like, with the HRT decision is you're adding to a small known increased risk of breast cancer, which is quantified and known, a possibly unknown small theoretical risk of recurrent SCAD. So, you already have these small risks associated with HRT. So our view at this time is that if patients have debilitating menopausal symptoms, we don't feel that the data is strong enough to say that patients in that context should not take HRT. We recommend that if they do take HRT, they take the lowest dose for the shortest duration that's possible to alleviate their symptoms and manage them through the menopause. Of course, that is the same advice that we give to patients who are having HRT who haven't had prior SCAD because of that small increased risk of breast cancer and so on. So I don't feel that HRT is contraindicated in SCAD. I think it's something for people to weigh up on an individual basis on the, if you like, on the basis of the things that I've sort of outlined to you there. There may be other things, other remedies that people try that they find helpful for menopausal symptoms. Again, I'm pretty relaxed about those things. Just always worth being careful and checking ingredients of things. But if you find something that helps you, then generally speaking, I'm in favor of things that make people feel better.
Thank you. So, there were quite a few questions along the lines of that. So I've sort of, I think you've really answered all of those questions. There was just one, there's been comments from quite a few people that feel that cardiology in general has very little interest in female patients' hormone status, and because of that, they don't feel that they're perhaps listened to as well as they could be. And do you know what the reason for that is?
Well, there are lots of reasons. Of course, first of all, you know, as I'm sort of living exemplar of, in a sense, interventional cardiology is dominated by men at the moment. There are more women coming into the specialty, and we welcome them. But any, you know, that is a transitional process. But, you know, I think more than 9 out of 10 interventional cardiologists are men at the moment. And so, you know, that has an impact. Also, I guess, you know, for most cardiologists, because atherosclerotic heart attacks are more common in men, again, that predominates in terms of their experience. So, I mean, that's not really an excuse, but it's perhaps an explanation. And, you know, it's something that I feel quite strongly about, that we need more dedicated services, certainly for SCAD and potentially for women and women's heart disease in general, because of these being able to, you know, we've just had a nice series of questions about pregnancy and pregnancy risk, and the menopause and management of the menopause. And of course, you know, these are not questions that most interventional cardiologists are used to addressing in their clinics. And what that means is that we just, you know, we need a small number of centers in the UK that are geographically distributed so that people can get to them from different parts of the country, that are able to give this advice, treat SCAD and conditions like it. Takotsubo, of course, again, has a female predominance, and look after those patients. You know, I think our experience at the moment, at least, is that, you know, our service is very challenged, and you know, we would love it if there was a change in perspective on managing women's heart disease in the UK, so that we could improve our service to SCAD patients.
Yes, thank you. So the final questions have been about the research and where it's going next, and questions along the lines of hormones, for instance, has been an area that people have concerns about, and links to causation of SCAD. So as a summing up, really, I know you talked about the various papers that are coming along, but what is your next research goal, do you think, going to be? Have you any idea? I've got lots of goals.
So, I mean, you know, there's been a lot of descriptive work, and we're really finishing that descriptive phase, I think. Clearly, we're looking forward to and very excited about Alice's project and Anya's work as well, looking at what we call omics, so looking at the proteins, the genes, the RNA, the little stepping stones between genes and proteins, to try and understand the underlying causes. So there's quite a lot of stuff in the pipeline to look at those things. I think also, hopefully, you know, the aim, if you like, of focusing on the genetic studies is that those help us to, you know, to identify pathways and potential routes, both in terms of therapeutics, so how might we approach treating patients with SCAD, and that's, you know, really important, and also just trying to understand the underlying mechanism. So I think what we will see is that the genetics work that is being done now, and, you know, is partly published and stuff still to come, will open up further questions that will allow us to drill down more into our understanding of the whys. And then in parallel with that, there are a number of clinical trials that are being developed. There's a clinical trial in Canada with our Canadian colleagues, and also a clinical trial in Spain with our collaborators there. And, you know, we will seek to support these clinical trials as they evolve over time. And those clinical trials will start to answer some of the questions, you know, aspirin, yes or no, beta blockers, yes or no, you know, other things, you know, in stepwise fashion, we can actually provide robust data, rather than at the moment what is predominantly observational data, and saying, well, okay, there's a little bit of data that might suggest beta blockers reduce the risk of recurrence, but it's observational. It's just saying that some patients who are on beta blockers seem to have a lower risk in one population that was measured. So these things need to be firmed up with proper clinical trials. So I think, that is the direction of travel. I think that, beat SCAD, and you all should be, give yourselves a pat on the back, because, the progress that has been made in SCAD research in the UK and internationally. So we, again, I applaud my international partners here over what is a relatively small timescale of some small number of years, compared to the, time that people have been researching atherosclerotic heart disease or cancer and these things, people have been working on them for, decades and decades. The progress that's been made in a small number of years, with both your financial support and in some cases your body's on the line and scanners and bits of skin, goodness knows what else, that, arms to be bled and things, these are the things. And also, we should also applaud our volunteers who've not had SCAD, but who've stepped up to the plate to get in the scanner, give a bit of skin. I don't think there's a relative of mine that's not sort of, given an arm, and, it shows that you have this amazing community because of the progress that's been made.
Thank you, Dave. That's just wonderful. I think the way that you explain things is in great lay terms so that we can all understand. And that's very refreshing for a lot of us who can sometimes find all the technical details quite difficult to understand. So we really appreciate the fact that you explain these things so well to us, because it really makes a big difference. Thank you.
No worries.